Thank you for joining me on this edition of the Profit Playbook, How to End 2025 Like a Badass, like you all are. So we are going to be talking about health insurance and employee benefits and all those kinds of things today. Quick reminder, do not forget to get your summit ticket. For any of you that are Pharmacy Badass University members, you do not use this link. You use the private link inside the membership, so you save your hundreds of dollars on your ticket. But for everyone else, pharmacyprofitsummit.com is where you can grab your ticket. We are going to be discussing AI bots, delegation, over-the-counter stuff, listening, like how to listen. Bradley James is going to, I swear, change everybody's life who listens to him. It is going to be an amazing, amazing show. And if you're interested in joining Pharmacy Badass University at all, have any questions, this is the place where you can go get some information from our website. You can always contact me too. I'm happy to chat with you, but my goal is to give you more time, more profit, and help you have more patient impact, because obviously that's why we are all here. So, all right. For those that are Pharmacy Badass University members, all of the information, the replay of this, and the content will be in our pharmacy profit matrix. I'm going to stick it in the expense ratio. There's actually probably a few places this can kind of go, but really the angle of Journey Health is not to just provide benefits, but actually to help you save money in the goal of providing benefits or being able to put together a benefit package that really fits your custom needs. And so for me, I think that lands in the expense ratio where it's helping you reduce your expenses for something that you might already be paying a whole lot more for than what you should be paying. So all of our members can go find all the information under the expense ratio. Just to introduce myself, I know many of you have been following Heather along in this webinar series. So just in case you don't know me, want to make sure we become friends. I am Dr. Lisa Faast. I'm the founder of DiversifyRx and Pharmacy Badass University. Here's all of my contact information. Never hesitate to reach out. I wake up and live for you guys every day. So you guys give me purpose. So never hesitate to reach out. Always happy to help if I am able to, of course. And then our special guest today is Anthony from Journey Health. And I will say, again, as I kind of talked about earlier, as people were still joining, it is hard to dive into a full health benefit and alternatives, traditional health benefits in an hour. So we're going to plow through a ton of information. And I will say that my best advice for anybody on this call or anybody listening to the recordings, I know a bunch of you are going to be listening to the recording, is to just have a call with Anthony and his team. So my call with his team for our benefits here is next week. I'm doing the exact same thing. I'm drinking my own Kool-Aid because everybody's needs are unique, especially when it comes to health benefits. There's so many nuances. So we're going to give you a lot of information. It's a little bit drinking from a fire hose, give you an over idea of like what Anthony and his team can do for you guys. But to really see how it's impact you and options that you have based on your situation, you're really going to have a call. And I know all of us don't like picking up a phone or scheduling appointments, but this might be one of those things. I promise you it'll be worth your while. So I'm going to kick it on over to you, Anthony, here, and kick it over to you in the agenda. And you can actually have control of the slides. You can move them. So feel free to take it away.
Perfect. Yes. And just so slides, make sure, how do I take control of them?
You should. Let me see. Maybe all right. Sorry. Okay. Now you can just, sorry.
All right. Perfect.
You should be able to just like click your mouse or push the button.
Or unless you want me to share my screen?
No, go for it. I'll just move the slides for you. That's all right.
All right. Perfect. Yeah. Sorry about that. So, hey, thanks for having us join. This is a interesting one. A lot of times we're working with businesses and manufacturers, small businesses, medium-sized businesses, distributors, and they have no idea how the healthcare system works. Obviously, meeting with you guys and talking through with pharmacists, you guys are interacting with insurance every single day. So you have a very unique point of view and perspective. And one of our founding members and board members is a pharmacist himself. So got a little bit of a purview. So this is I'm sure you guys bring definitely a unique point of view. So today, I'm going to give you an introduction of who Journey Health is and what we're doing. Tell you a little bit about the current state problems from a macro perspective, what we're seeing in the United States and insurance. Give you a little bit of a background how we got here. How did this all come, and why is it getting worse? Give you some kind of one-on-one basics around health insurance, group health insurance, and then really talk about the path forward and our solution specifically. So, like Lisa said, it's a lot to cover in an hour, but I think it's important for every citizen, for every individual, and especially business owners as yourself, to be fully informed. And so, a lot of times we'll see a lot of solutions out there. Or we'll see kind of gloss over on kind of what the problem is and the solution. But I really, my intent and what we're passionate about here at Journey Health is not just bringing forth solutions, but also educating our clients and our partners on really what's happening so that you can be more informed decision and employer. So introductions, go to the next step. So we are a group and individual health benefit ally that's insurance agnostic. So we can provide unbiased benefit options. If you look at the current state, and I'll get into specifics in a minute, a vast majority of health insurance and group health benefits are procured through brokers. And those brokers are compensated directly from the insurance company. So our goal is to really come in and to provide an unbiased benefit option to really help educate and inform you. Our goal and our mission is that every employee and every family member gets the quality care and coverage needed without overspending. And I'll get into some of those specifics in a minute. And what we do specifically for employers is, we provide a superior group health plan that includes employee retention and satisfaction. So we save most employers about 25% annually, while also giving them a much better benefit. So current state. So I've got a few slides here to kind of talk about, what we're seeing. A lot of you guys have experienced this, are living in it day and day, specifically when it comes to prescriptions. I do want to preface, I'm not going to dive into the pharmacy side in depth today. Obviously, there's complexity there. There's changes coming from the current, administration in Washington. So the pharmacy landscape is continuing to change. I'm going to keep it more broad of group health benefits in general. If we look in the United States, we're seeing on average 10 to 20% increases in health insurance costs year over year. So we've seen rising medical costs, rising insurance costs. So on the surface, you say, okay, well then obviously we're having a superior care. We're seeing an increase in quality of care. We're seeing an increase in health. But that's the problem. At the same time, while costs continue to rise year over year, we're seeing a significant decrease in patient health. As a lot of you are aware, dealing with your patients and your members every day, there's such an increase in chronic health due to food, chemicals, environment, stress. And then really on top of that, the whole primary care system's breaking down as well. And I'll get to those specifics in a minute. But also beyond that is there's just a lack of holistic health education and awareness for patients and physicians. This system is built so that profits increase as people get sick. And it's really not a sustainable path for America. If you want to go to the next slide. So specifically around health insurance, I like to break it down. This is getting in a little bit of one-on-one, but really there's four primary options. If you're an employer or if you're just a citizen of the U.S., you've got four primary options. One is traditional employer-provided insurance. That's what a lot of people are familiar with. About 65% of Americans get their insurance through this channel. That's your traditional Cigna, Aetna, United Healthcare, Blue Cross, BUCA, they like to call it, provided from your employer. The second one is the ADA marketplace, obviously Obamacare. You guys may be familiar with this, but as an individual, you can go to the marketplace and procure benefits on your own individually. Another is the Medicaid, Medicare. So this is typically for retired. It's public insurance for disabled, for vets. And then there's cost sharing. There are about 2 million Americans in this today, but this is, was traditionally, reserved for faith-based, but, the MediShares, Zion, New Health, Sedera, it's an alternative way to pay for healthcare. But when you look at each of these, traditional employer-provided insurance, the costs are going up and the care is decreasing. For the marketplace, there is reduced cost for low income, but it lacks the quality. Medicaid, Medicare, VA, it's not a ton we can do in that space, but there's definitely a lack of quality care in there. And then health shares, they reduce costs significantly, but it really lacks preventative care that most Americans are used to. If you want to go to the next slide. This is just a slide to show where insurance is going up. So last year, the average cost for health insurance for a family of four in America was $24,000. That was for 2024. That has increased now. They just released it. It's 27,000 per year. So the average family in America is paying almost more than mortgage and rent for health insurance, and it's going up every year. They're expecting next year, 2026, to be one of the largest increases ever. We're seeing some of our clients see 30, 40, 50% increases in their health insurance for next year. It's not sustainable. And if we continue to do that over the next 2, 3, 5, 10 years, as you can see, there's no telling where it's going to go and the impact it's going to have on the economy and how it's going to be paid for. It's not sustainable. So if you go to the next slide, and really it's just the administrative bloat and just kind of the burden that's stuck in the middle. So, I'm not going to read this line for line, but, like, how did we get here? Why is it like this? There are just so many administrative costs happening in the middle between the point of care and the insurance providers. And it's just not a sustainable path. And then the last piece is primary care. So we talked about, hey, cost in the United States continues to increase. And we're seeing that directly tied to the cost of health insurance and the healthcare system. But on the same time, we're also seeing a decrease in the quality of care. I would say the American medical system's doing a really good job for acute care. If we get cancer, stroke victims, prenatal, premature births, those types of things, we're seeing great technology and great advancements. But when you look at just chronic care, it's not working. So, the big problem is that it's really at the primary care. 80 to 90% of all issues can be solved and are handled in primary care. But today, they're owned by the large hospital systems driven by profit and insurance. I'm based out of Charlotte, North Carolina, so we have Atrium and Novant here. On top of that, the reimbursement rates for primary care continue to decrease. I was talking to a primary care doctor, part of the Atrium network, and he's saying he's running close to 4,000 patients on his roll a year. He has to see 4,000 patients. And he's like, that's the only way they can barely break even. It's because the reimbursement rates are so low for primary care. So with that being said, when you go to a primary care doctor in one of the large systems, if you go in for a physical, you might meet with a nurse for 10 minutes, and then you meet with a doctor for 15, 20 minutes max, may even be 5 to 10. And then, when you're sick, 5 to 10 minutes. And so when you come in, they don't have time to work with you on your sleep, on your diet, on your vitamins, on your holistic care, on your everything. All they have time to do is to really prescribe pharmaceuticals to fix the problem. They can't get to the root issues. It's not because they don't care. It's not because they're bad doctors, but they're part of the system. And they just don't have, financially don't have the time to spend with patients they need. And so hence why we're seeing so many chronic issues in the United States today. When we look at diabetes, obesity, high blood pressure, and autism, ADHD, all the things that you guys are aware of in your pharmacies. So it's really becoming a problem in the U.S. as we look at the overall insurance system as well as primary care. And these are some of the problems that we're looking to solve. Great. So how do we get here? So I just wanted to kind of put out kind of the history. I mean, before the Great Depression, healthcare was really out of pocket. You had, community hospitals, and it was cash based, and you paid as you needed. Very simple, very straightforward, without all the administrative costs, the middlemen, and the bloat. Then what you had in the 1930s and 40s, really after World War II, there were wage controls in the United States. And so employers, the government set up tax incentives for employers to offer employer-sponsored health insurance. And that's when you really had the first Blue Cross Blue Shield employer-based insurance set up. And that is really where it started, was post-World War II and around World War II with wage controls. Shortly after that, in the 60s, you had Medicare and Medicaid expand coverage. that's when we really started seeing costs accelerate. In the 70s and 80s, that's when we got into all these different types of networks. You heard of HMOs, PPOs. We're going to get into some of these in a minute, but that's when you started seeing all these variations and all these different setups. And then the employer premiums really started to take off in the 90s and 2000s. That's when you really started to see these high deductible plans. I remember 10, 15 years ago, a high deductible was 2,500. That's manageable. At least in the grand scheme of things. Okay, I pay my premiums and I might have to pay $2,500 out of pocket a year. Not great, but manageable. Today, we're seeing majority of deductibles in the range of 7,500, 10,000. We're seeing some above 10,000. So, an employer and employees paying a significant amount of cost on a monthly basis for the premiums. Then when something happens, a middle class, American middle class families having a $7,000, $10,000 bill just for a broken arm, and it's not sustainable. And then in 2000, in the 2010s, 2012 is really where it changed. So the ACA mandates exchanges and compliance. So the ACA was put in place. And one of the big reasons that we've seen costs really increase over the last decade truly is a law they put in place that said insurance companies can only accept 15% of their revenue as profits. They put caps on the profits. So on paper, that's good. That's controls. It's keeping the system in check. It's keeping the insurance in check. But what has happened is because the insurance are publicly traded companies, they have a fiduciary responsibility to their shareholders. What we've seen is that they say, if we have our profits capped, then we're just going to raise our top line revenue. So if you guys have ever been to a hospital, ever had a surgery, and if you looked at your line items, you might see a box of Kleenex. It was like $100, $200. Obviously, if you go to the grocery store or inside your pharmacy, that costs $2, $3. And you probably wonder why. Well, that was set by the insurance. It's a way for them to increase their profits. Hence, why we've seen the cost of healthcare go up year over year is basically because of that rule capping the insurance company's profitability. So that's where we're at today. But we're seeing in the last few years is some shifts. We're the pain is getting great. So we've seen some alternative funding models we're going to get to, something called ICRA, which is great, come into play. So we're seeing really a shift and a transformation as we talk about today, which is really exciting. So now that was a little bit about the problems and what we're trying to solve, a little bit about how we got here in a timeline. Now a little bit is just 101 to make sure you guys are fully educated. Some of you watching here and listening may know all these terms. There may be some new information you gain for others. But we'll just kind of give you kind of high level overview so that you can be an informed decision maker moving forward. So as you know, these are the key players, nothing new here. Employer. So, I think one of the large misconceptions in the US is that insurance companies are paying for health insurance. They're paying for medical costs. Well, that's not really the case. The health insurance companies have really passed on the cost to employers and employees. So, I think one thing I want everyone on this call to really kind of grasp is it's not necessarily the insurance companies paying for insurance. It's the employers and the employees and the families paying for insurance. Hence why the individual costs continue to get passed down. Insurance carriers just pull the risk, process claims, and set premiums. And as we talked about before, they keep 15 to 20% of those due to the MLR, medical loss ratio. PBMs, you guys are well versed in that. That's a whole nother webinar, and I'm not even going to try to act like an expert in the PBM space. But obviously, PBMs have had quite the impact on rising medical costs. I'm sure as you guys are aware. The hospital systems, they also are key. As mentioned before, the hospital systems, while they are nonprofit and continue to have huge tax incentives, they don't act in that manner. So they're continuing to acquire many of the specialty clinics. They continue to own a lot of the primary care, and primarily they're working directly between pharmacies, hospital systems, PBMs, hospital systems and insurance carriers are really working together in a triangle to really set those rates, set the premiums, and to drive the cost in the system. So the next is around procurement. So it's like, all right, if I'm a business owner, small business owner, medium-sized business owner, pharmacy owner, any business owner, how do I procure benefits? And I touched on this in the beginning. Majority, 80, 90% procure health insurance in the United States through a broker. Just like, 90% of Americans procure a house when they want to buy or sell a house through a real estate agent. In the insurance space, it's through a broker. Brokers are paid commissions built into your premiums, sometimes bonuses from carriers. I like to liken it to, what if your CPA was compensated from the IRS? What do you think would happen with your tax bill? I'll leave it at that. It's the same concept. So, for a 30-person business, a broker might collect a $30,000 a year commission without you ever seeing the bill. A couple other ways that are less common but are out there, especially for small businesses, something called a professional employer organization, a PEO. They typically come in and say, hey, it's kind of like, hey, you're going to join, you're going to be part of a group of 20 other employers, and we're going to negotiate on your behalf for HR, payroll, compliance, and benefits. Sounds good in theories. You might get a little bit better rate, having those kind of bundled services, but you're essentially renting space in theirs. You really have no control, no say, and as rates go up, you feel stuck. And then the other would be payroll providers, very similar to PEO, the ADPs, the Paychecks of the world. They'll add in, hey, we've got insurance if you want it. And there is some convenience there for sure of, if you're a small business and to be able to say, oh, that's easy, I'll go ahead and take it through ADP. But again, you're beholden to the increases and the increase in cost year over year. And there's, you're limited in your options and your control. And we go to the next slide. So the next part is, okay, I now understand benefits, how we got here and the problems we're facing. I understand how, if I need to go out and procure it, I understand what my options are. Now, what about the financials? How's this work? So the first is really going to be the premium. So, this is obviously what you're going to pay on a monthly and annual basis. I'm going to get into splits here in a minute, but that's set by the carriers. And typically it's based on claims history, age of employees, location, and group size. So anytime we do a census, we're typically asking for a zip code and for ages. But the problem is that the, 80, 90% of healthy population or healthy employees or younger employees in a business are paying for the 10, 20% that maybe aren't. And so there's some disproportion there. Like in a small business, a single high cost claim. So let's say you have a business of 10 employees, and let's say one patient, one of your employees, unfortunately, comes down with cancer. That could trigger a big renewal increase for everybody in the company. And we see it time and time again. So, when you think about your contribution, a lot of small employers are trying to cover about 70% of the premiums because it's so expensive for employees. That's leaving the employees to cover 30%. By no means do you have to offer 70%. It's completely up to you. If you're under 50 lives or 50 employees, it's really up to you what you want to offer. So if you say, I just want to offer $100 a month, I want to offer $200 a month, I want to offer 50%, I want to offer 25%, there's flexibility there. But I just want to kind of give you some examples of thinking about employee contribution and how that's structured. It's completely up to you, and we'll work with you to figure that out. Some of the hidden costs that are out there are admin fees for COBRA and ACA reporting, broker commissions that we talked about, PEO markups, and really that lost productivity. Because what we have found is that employees on high deductible plans, instead of getting the care they need, instead of getting that surgery that they need, instead of going to that specialist and getting that MRI or getting that test that they need, they'll avoid it because it's so expensive. If someone who's middle class, raising a family, and it's going to cost them from insurance, let's say $3,500 for an MRI, they're like, I don't know if I can afford that right now because of the deductible. And so that downturn is going to affect their health and their productivity as from an employee standpoint. So most SMBs, small businesses like yourselves, are paying more just because you lack visibility and education of what all your options are. So now we talked about kind of the financial side. How do we procure it? How much money do I contribute? How do I structure it? The next one to talk about is really plan types. There's a lot of acronyms out here, and this is just some of them. So I just want to make it simple so you're aware. Not all these will apply to you, but I want you to be well versed as you guys explore. So PPO. So this is considered a preferred provider organization. These are pretty flexible. Sorry, I'm getting over a little bit of a cold. And larger networks. So they're ideal from that perspective. It's kind of open. You can go to any doctor you want for the most part, but these are going to be significantly higher costs, significantly higher costs. These are going to be your most expensive plans. An HMO are typically going to be a lower cost, but it's going to be a really tight network. And typically, these is where you require your primary care for referrals. So, require you referred from your doctor and have to have the pre-authorization. You're getting into all the restrictions, and that's not ideal. You might be a lower cost, but to feel like every step you take, I have personal examples, where my son had some stuff in the past, and I had to go through and like chase down providers just to get referred, or I had to go through extra steps, extra tests, extra specialists just to get approved. That's not how it's designed. If you have something wrong, if a family member has a need, you want to be able to go get the care. You pay a lot of money. If you're paying $24,000 for a family, you want to be able to go get the care you need without jumping through all these hoops with fire in them. So it's not ideal. And then high deductible health plans. That's the third most common. We talked about in the past. It's a lower premium, not great, but lower, but high out of pocket costs. And we continue to see it go up and up every year. So, an employee might, or you as an employer might select high deductible health plan for your employees because that's all you can afford. And then your employee might take that plan because that's all they can afford on a monthly basis. And they think they're taken care of. But again, if they have a $10,000 deductible and they break their arm and all the bills related to that broken arm equal $12,000, well, guess what? They're paying $10,000 out of pocket. A lot of Americans don't have $10,000 sitting around for that broken arm. So it's a broken process. And on top of that, though, and I didn't get into it in here, you have copays, out of pocket max. So all the other costs and fees and then items that aren't even covered in the plan. So, when you start adding up all of these costs, it gets really, really expensive. Pharmacy gets very expensive for both the employer and the employee. So, the second piece that I want to talk about is what we call our funding models. So this is a little different. Earlier, I was talking about how do you procure? It's kind of like, how do I even go get insurance? And then how do I actually set it up? How much do I pay towards it? Then it's like, okay, I got a broker. I know how much I want to contribute. Now I need to select my plans. But there's actually a few other funding models that I'd like to get into. One is going to be most common probably for everyone on this call would be fully insured. So fully insured just means you pay a fixed premium, carrier takes all the risk. So it's saying I'm going to get a broker and I'm going to get a Blue Cross PPO plan and a Blue Cross HDHP plan, and I'm pretty much taking on all the costs. There's no discount, there's no flex. It's take it or leave it from the insurance company. So it's pretty expensive. But the carrier takes on all the risk for the most part. And so that's why they're going to raise their rates on you in the following year if there's a big incident like cancer or something else. Level funded, I would say we're seeing this a little bit more at kind of like the 100 to 300 employee space. You pay, it's more of a hybrid. You pay a set monthly rate, but you can get refunds if claims are lower than expected. There's some complexity here. It's not straightforward, but we're seeing a rise here in kind of mid-sized employers, and then self-funded. So really don't see self-funded and really in less than like 300-400 employees. It's really reserved for, your large enterprises, Fortune 500. I believe about 90% of employers over 1,000 are self-funded. but I think it's just good for you to be aware of, especially as you're talking to patients and such. Essentially, in a self-funded world, those employers are becoming the insurance company. I know it sounds crazy and ludicrous, but that is what's happening. They are essentially saying, hey, I'm going to get a third party administrator. They're called TPAs. And I'm going with that TPA, I'm going to determine what I'm willing to pay, what I'm not willing to pay for. I'm going to determine what my network is. I'm going to work with a cancer specialist network in case that happens. I'm going to work with an orthopedic network in case that happens. I'm going to set like a stop loss, a captive. I don't have time to get into specifics because I don't believe this applies to many of you, if any of you that are going to be listening to this, but just so you're aware of what's happening out there, the reason that large like employees, individuals can sometimes have, somewhat cost-effective health insurance through these large like Fortune 500 employers is they've essentially become their own insurance companies. It wasn't because they want to. Tech companies or large global manufacturers didn't wake up and say, hey, all of a sudden, let's get into the insurance business. They were really driven here over the last decade by necessity. The fully insured plans were so expensive that they had to go. It was the only alternative. They had to do something to contain the cost. But the unfortunate thing is, in the small business world, you can't do that. You don't have the resources. So you're stuck in that fully insured world, and you're stuck with that 10, 20, 30, 40% increase every year. And so another option, which we're seeing grow, and I'm going to get into more specifics later, is ICHRA, individual coverage, HRA. And this is what we found as a better way for small businesses to procure group benefits. And essentially is saying, I'm going to give the employee tax-free money, and they're going to be able to buy their own ACA compliant plan. So think about the shift from pension to 401k. You had pensions 20, 30 years ago, and then employers started saying, hey, we're going to contribute, and then the employee can decide what if they want a high risk, low risk, money market savings, whatever they want. Same concept. It gives the employee to choose. They want high deductible, low deductible, Blue Cross, Aetna. It gives them more freedom. All right. So we've got about 25 minutes. So what's the path forward? So I'm going to talk about a concept called the parallel health economy. The concept of parallel economy I'll get to in a minute. It's growing. We've seen it in so many industries. And so, this concept of ICHRA, direct primary care, medical cost sharing, cash pay truly is the path forward. And I'll get to that in a minute. If you want to go to the next slide. So some examples of a parallel economy. So as you guys remember 15 years ago, never even heard of Airbnb. You go on vacation, you basically stay in a hotel, or maybe you had a rental company at the beach. These days, Airbnb and VRBO. 20 years ago, you wanted to consume the news. You basically had, radio. You had a little bit of radio, newspaper, but for the most part, most Americans watch CNN or Fox or NBC, whatever their choice is. These days, all those networks are declining. Majority of people are consuming through Joe Rogan, Sean Ryan, YouTube, Spotify, whatever you enjoy. They're consuming their news and gaining their news from Twitter, from other areas. Same thing with taxis. 20 years ago, you need a ride in New York, you got a taxi. That's all you knew, or you rented a car. These days, Uber, and then eventually it will be Waymo. If anybody's been to San Francisco and self-autonomous cars, Uber. And so when you think about it, every industry makes a shift to a parallel economy. Hilton, CNN, taxis still around. They didn't go away. I'm not saying they become obsolete like Blockbuster, but these parallel economies grow. And we're seeing the same thing happening in healthcare because the pain's so great and it's not on a sustainable path. And employers are waking up. It's like, I can't do this. I can't afford this. Why? Why is a box of Kleenex $300? Why is my MRI $3,500 through insurance, but $500 of cash pay? Doesn't make sense. And so it's taking time, but we're seeing it grow. So if you want to go to the next slide, Lisa. So some common themes in parallel economies. They have to disrupt the payments. So obviously, all those before you saw there was payment disruption. You think about Uber and Airbnb. They have to remove middlemen. I mean, that's where the cost, and we talked about it earlier when we talked about those administrative costs. The middleman is where everybody's getting their piece of pie, driving the cost up. They've got to correct bad incentives. So we just talked about, the brokers being incentivized from the insurance companies. We've got to be able to pull them out and pull that piece out. And the last thing is they're not going to come from legacy players. So United Healthcare is not going to wake up and saying, "Yeah, let's go do Uber." Like the taxi industry didn't wake up and say, "Hey, let's go do Uber." No, they saw it as a threat. They wanted to protect what they've had for so long, and so it takes outside influence and others. There's millions of Americans working on this today. You hear Mark Cuban, what he's doing in the pharmacy world, but there's just so many out there that are really driving this parallel economy forward. Some of the key factors that's shaping this, I just talked about, there's a crisis of affordability. That's what it really comes down to. It's not affordable. Like on top of the inflation in housing, inflation in gas, inflation in food costs, everything else that everybody's aware of, people can't afford healthcare anymore in the United States. Middle America, average Americans, average employees, small businesses can't afford it anymore. It's hit that inflection point. The networks and third party payment have outlived their usefulness. Doctors love cash pay. Physicians love cash pay. We're seeing, I'm going to get into direct primary care in a minute. There's a mass trove of primary care doctors leaving large systems to go on their own to cash based direct primary care. They don't want anything to do with insurance. And our co-founder is a direct primary care physician. So I'm well versed in that space. The massive administrative bloat, that sounds like a broken record. I think we're all aware of that. You guys know that from a PBM standpoint, and the misaligned incentives. So I don't want to beat a dead horse here. I'm going to go to the next slide. But it's not easy, is the last thing. We have Stockholm syndrome with insurance networks and third-party payments. I'm talking to individuals, employers, small business owners, CFOs every day. And they're like, "Man, I don't know. I can't do this anymore financially. This is broken. It's not working." But this is the way it's always been. We were taught 20 years ago, 30 years ago, however old you are, 50 years ago, get a good education, get a good job, get insurance, right? That was kind of the American way. Education, job, insurance. And we always thought that we had to have insurance. And I think that made a lot of sense when insurance was relatively affordable. But what's happened is it's changed so much over the last 5-10 years is that it's not the best option anymore and it's not sustainable, but still it's hard for people to change. And so we do still have some Stockholm syndrome in America today in regards to insurance networks and third-party payments that we still have to break free from. So if you look at the 4 pillars of the parallel economy, direct primary care, medical cost sharing, ICHRA, and wellness programs, and I'm going to get to each of these. I know we just have 20 minutes left, and I want to be cognizant of time. You want to go to the next slide, Lisa? So what is ICHRA? So I'm going to start here because when I work with employers like yourself, employees, anyone, the first question is, well, my son has this condition. My wife has this condition. My employee had just got over cancer. Our mind always goes to that 10-20% that has something going on health-wise, and rightfully so. Like, we are not anti-insurance at Journey Health at all. I absolutely believe insurance is a fit for certain people. But reality is, traditional insurance in its current state is probably only a fit for 10-20% of people. The other 80% are relatively healthy, and there's a lot of other options. But I want to start with ICHRA because I want to make it clear I want to make sure that those that have pre-existing conditions, or those that have really expensive pharmaceuticals, or those that have something really going on health-wise, stay on traditional insurance if they need it. But if they need it, let's give you, the employer, and let's give the employee another way to get it. So right now, I talked about it, traditional way. I'm an employer, I'm going to get a broker, I'm going to get a group plan, and I'm going to give my employees 1, 2, 3 options. And that's what they get. And most of the time, these days, it's going to be a high deductible. Take it or leave it. We're seeing participation rates in a lot of group plans go down to 20-30%. Most employees are saying, I can't afford it. I'm going to roll the dice and not even have insurance. And so, because they're so bad now, Well, there's another way. In the ICHRA, so ICHRA is fully approved by Trump administration in 2019. It's well established. It's the fastest way to procure, and it's just an alternative to a group plan. It's another way for an employer to offer benefits to their employees without going through a traditional group plan. And so basically, you still go through the payroll. There's still open enrollment. We still help, or the platform still helps decide. The employees decide which plan to take. So all that's still in place. There's still tax deduction, but basically you're saying I'm going to set a contribution, $200-300 a month, and then the employee is going to select from the marketplace. Do they need a gold plan, a silver plan, a bronze plan? Do they want high deductible, low deductible? Give the employee the choice. Let them pick and decide what they want. Do they want PPO, HMO? Let them pick. So then they can decide and get the coverage that's best for them and their family. If you'll go to the next slide. And here's some just kind of bullets of group versus individual. The thing with traditional group plans is every year you get complex renewals and increase in pricing. People are minimum participation, minimum contribution. You as an employer are responsible for picking everything out, and you've got that fiduciary responsibility and that claims risk. If something happens and someone on your team, gets something severe, like talked about, you got to worry about your premiums going up for everybody next year. If we're in ICHRA, none of that. So it's personalized. All you do is you set the budget. There's no minimum participation, no minimum contribution. It's ACA compliant if you are over 50 employees, if some of you have multi-branches or multi-sites, but the employee picks and they get the flexibility they need. So if you want to go to the next slide. So that's ICHRA. So that's one piece. Is like, hey, for those that really need insurance, let's look at ICHRA. But for those, the 70, 60, 70, 80% that are healthy, they're like, I haven't been to the doctor in 2 years. I want to pay the bare minimum and I want catastrophic. I just want to know that if something happens, if I break my arm or if I get cancer or if I have a heart issue, I just want to know I'm taken care of. Other than that, I want to pay the minimum. That's where health shares come in play. So health shares have been around for a long time. There's over 2 million Americans today in health shares. So they originally started as faith-based. So it's like Christian healthcare ministries, Medishare, but they've evolved. Now they're open, especially the ones we represent are open to all individuals, regardless of their faith. And so basically what it is the member contributes a monthly share, which is like a premium. And then as funds arise, those bills are directed to the health share and it pays for that. So it works typically under something called an IUA. So instead of having a $5,000, $7,500 deductible, you have per incident. So that example earlier I used of a broken arm, and if someone has a $10,000 deductible, having to pay $10,000 for a broken arm, if under the health share, if you have a $1,000 IUA or a $1,500 IUA and you break your arm, everything related to that. Complications, you get an infection, you got PT, you got surgery, all that, you pay $1,500 out of that. So you've got 20 to 50% lower premiums, and you don't have the big deductibles every time something happens. It's really, really good, especially if you pair it with like direct primary care or a wellness program. It's a great option for a lot of Americans, especially ones that are relatively healthy and just want catastrophic coverage. So if you want to go to the next slide. This is just kind of a conceptual overview. You got a pool of people, they contribute, obviously monthly, kind of like a premium. It goes into a not-for-profit community. That money stays in there as administrators, and as things pop up, that pool of money is paid. It's really how insurance should have been, and originally the original idea of insurance, 80, 90 years ago. Sorry, I take a swig of water. Doing a lot of talking here, Lisa. And so the other pillar that we talked about, direct primary care. Direct primary care is the fastest growing segment of primary care. As we talked about earlier, physicals and primary care and chronic care issues in the U.S. it's not working anymore. So there's it's getting up to about 3,000 direct primary care clinics in America today. It's mostly doctors that used to work for big systems that have broken away. What it is, it's like affordable concierge medicine. A lot of people are familiar with concierge. It used to be for the wealthy. You pay a high monthly premium, and you essentially get to go see the doctor whenever you want. And they do a lot of fancy medical stuff, and you get a really high level of care. Well, it's really come down for average American. And so what it is, it's monthly membership for primary care, doesn't take insurance. And then basically you get unlimited visits. You get as long as you want. They'll spend an hour with you. They'll meet with you every week. They'll run labs. They get into vitamins. They get into diet. They get into sleep. They try to get the root cause. They don't just prescribe scripts. They still, prescribe. There's still a place for prescriptions, but they really try to get to root cause. They really try to work with you to really kind of true wellness and holistic health and really kind of get to the root. So it works really, really well with ICHRA and health shares from a pairing standpoint. So if you want to go to the next slide. And then the last thing is wellness programs. So we're seeing this grow a lot. Wellness programs, there's a lot of different variations in the US of these. Some are doing more gym, some are doing more mental health, some are including different tools. These can be structured however you want. I'm going to talk to you in a minute about how the most common one we see is structured, but wellness programs also is another way to drive retention and drive employee health. If you want to go to the next slide. So our top solution. So here at Journey, we work with several different partners. If you need traditional cost sharing and that alone, we can help you. If you for some reason just need ICHRA, we can support you. If you want to figure out as an employer, set up direct primary care, we can help you. So we've got some different options, but what we've used the most here, and if you want to click through all the way, Lisa, there's some slides. I would keep clicking through and I'll just kind of talk through all together. We've already hit on most of these. So for the sake of time, we don't have to go line by line, but it's really a pairing of a preventative program that would go to all your employees. And in that preventative program, it will pay $70 a month for a direct primary care. So what we just talked about. So it almost covers, or in a lot of cases, covers direct primary care, but it also includes like mammograms, colonoscopies, $3,000 per year, mental health, physical health, dental cleanings, vision screenings. So that would go to all your employees, which is really cool from a retention and recruiting perspective. And then each employee has one of three options. They can say, I'm going to decline benefit because I'm on my spouse's, or I'm just going to roll the dice and I don't want insurance. Option two would be the co-op cost share. So this is the most common. Get them on something because they already have the preventative and they have direct primary care. Get them on a cost share for catastrophic. So in case they break their arm or something worse, they're covered. And then the third option is for those that really need it, if you want to keep clicking through, Lisa, would be the ICHRA. So those that have pre-existing or have a really expensive prescription, we'll get them on a Blue Cross United Cigna plan. So we can do all this in one bill, in one total package. We can also include dental and vision for your employees. So if you want to keep sliding through, from an employer standpoint, it gives you budget control and predictability. It's ACA compliant if you're over 50, and no need to choose a plan for your employees. It gives them the freedom of choice, and you don't have to go with this crazy renewal process every year. And if you go to the next one, and from an employee standpoint, they get freedom. They can choose whatever they need. That, if you recall from our first slide and what we're all about, that is what we're passionate about. We are not anti-insurance. We are not anti-hospital systems. We are not anti-healthcare. We just believe that there are a lot of options out there, and most employers, most individuals and families are uneducated on those options. So we just want to work with everybody, educate them on all their options are, and so that every individual and every employer can then have the freedom of choice to decide what's best for them based on their healthcare needs and based on their budget and the cost. And so that's the cool thing about this setup is it's putting choice. It's saying, hey, you need traditional insurance, you got it. You want to go on a co-op, you got it. It's taking care of them, and it's not restricting them in networks, and it's helping them from a financial perspective. So I left about 10 minutes. I don't know if we'll have any, but next steps, we're here to help. So myself, Craig on my team, we can work free of charge. If you want to jump on for 30 minutes, better understand where you're at, whether you're not offering benefits today and you want to offer something, or you are offering benefits today and it's getting out of control, or you just want to see what's out there and ask more questions. Another way too is I know a lot of you pharmacy owners are working with businesses in town, other small businesses, other business owners. We love referrals. We also have some referral programs that we can talk to you about one-on-one. So if you're really connected in your town or in your city or in your area, and you think this would be a great fit not only for you, but also would be a great fit for other employers and other businesses that you're talking to, or if you want to extend it to employees, we can talk to you as well about an extended referral program. So we've got a different options. Our main thing is the heart is we just want to help people and educate them. So reach out. There's a landing page directly here for the pharmacy. You can schedule time and love to see how we can help.
I do have a couple of questions that were sent in, Anthony.
Yeah.
So I have a pharmacy owner who has a small team. All of their team has either other coverage or they don't need benefits through the pharmacy, but the pharmacy owner wants benefits. How does that work if only the owner wants benefits? Because they've had trouble, I guess, finding some.
Yeah, yeah. So that's always a tough one. Typically, what we can look at there would be the marketplace and advising them. So, because really there on that point, you're looking at individual. Now, if you're looking for tax benefits, we can explore, a single ICRA. So we can help advise there. So at least that way, but even the ICRA is going to go through the marketplace. So I don't know the specifics of that individual and why and what.
Yeah.
So we can definitely talk to them. But yeah, more than likely they're leveraging the marketplace or ICRA to procure that.
Okay. Next question was, when can they, so they don't renew at the end of the year. So they have a renewal that's in the middle of the year. So do they have to wait for their renewal to switch plans or maybe go with something with you, or that there was a little bit of questions about the renewal time?
Yeah. So most common is people want to wait to the renewal date because a lot of times they think, hey, I've already paid in my deductible. So most common is we do it at renewal, but there are no limitations. You can cancel your insurance plan at any time. So if you're interested and the numbers add up, you can switch now. You do not have to wait for the renewal time. But in some cases, depending if someone, was already paying into a deductible and they didn't want to switch to ICRA, then it might make sense to wait. So it's case by case, depending on where they're at. But no, you can switch at any time.
And then another renewal question was the traditional, they're looking at they just got the renewals from their insurance company that they have health benefits through now. And it was increasing by 8% for one section and then like 15% and for another.
Right.
How long does it take to get started with any of your options because they don't want there to be like a lapse in coverage?
Yeah, absolutely. So we've got a few different, we've had times where we can usually get it implemented within 30 days. There's some extremes, like if we have to, and if it's straightforward, might be able to get it, quicker. But I would say, ideally we have at least 30 days. But, if we went straight ICRA and we're doing ICRA only, we can turn that around a little quicker. But I would say kind of rule of thumb is 30 days is ideal.
Okay. Those were all the questions that I had for now. So I know that was a lot of information, a little bit of backstory to make sure everybody kind of is on the same page because when you're talking benefits, words and definitions matter.
I
And
know.
so, as I said in the beginning, I recommend you just have a call with Anthony and his team. I myself am doing that as well. My call's next week, so I'll update you all. But because I'm definitely looking for some better options for my employees as well. So just to have a call and go through your particulars. Everybody's obviously health is personal. Your coverage and the benefits you want to offer to your employees is personal. And so just have that one-on-one conversation for the details of your particular plan. And you can get there by going to that link that was there. Whoops.
Yeah.
All right.
Yeah, everybody's different. Yeah, every situation's different. Everybody.
Yeah.
So, yeah.
All right. So those were all the Q&As. I don't see any others popping in. So if you have one on a recording that you're watching this, reach out to Anthony's team and just schedule a call. It's probably the best way to get that answered. I generally say, oh, I'll try to answer. I'm not going to answer about your health benefits. I know nothing about that. So I will leave that to the experts. So again, don't forget to get your Pharmacy Profit Summit ticket. I promise you, man, this one is I mean, they all change your life, but this one is going to be amazing. So get your summit ticket before the prices go up. We are a Saturday, Sunday this year, so I'm super excited about that. So you can fly in Friday night. You can even work your shift Friday night, fly in Friday night, attend the summit, and then head back home Sunday night. And so minimal time out of the pharmacy. And if you have any questions about becoming a Pharmacy Badass University member, go ahead and check out our website. You can find it there from our DiversifyRx website or our membership website. Honestly, I'm just here to help. So if you have any questions about membership, different levels or anything like that, just never hesitate to reach out to me. I'm here to make your life easier in all ways. So thank you so much, Anthony. Thank you so much to all the things that you're doing to help businesses. And now is the time, obviously, when a lot of renewals are happening.
Yeah.
As Anthony said, you don't have to wait for a renewal, but sometimes that is often the best time to make a change is during that renewal time. So thank you everybody for joining, and we'll talk to you guys all next time. Bye-bye.
Thanks, Lisa.